is about diagnosing the heart disease. Uh, as we know, diagnosing the heart disease require some symptom development, and patient goes to the primary care physician. Primary care physician think this is somewhat troublesome and send patient to cardiologist. Cardiologist see the patient and do the basic tests. The most commonly EKG and stress test. Based on these two findings, plus now we also have echocardiogram, some blood work and family history examination. Basically based on stress tests, we decide what we're going to do. If you pass the stress test, you go home and you're going to be okay, hopefully. And if you fail the stress test, then we have invasive procedure angiogram, and we go from there. So GMA angiogram, we find blockage or do angioplasty or don't find anything and we send you home. But the notion, this is the common concept. But the reality is the heart disease is not symptomatic all the time. The fact is the majority of the people coming to the ER who have a first heart attack, more than 50% of people, this is their first symptoms. They never have a problem. They never have a chest pain. They never have a shortness of breath. They're very healthy otherwise, eating well, partying, and whatever they need to do. Typical middle-aged man or woman. Suddenly they have a one-day chest pain and they cry for help, and either they or their family call 911 or they go to the emergency room via car or ambulance, and we found them, they have acute MI or heart attack, and we end up doing all the intervention or procedure we need to do. But this is their first symptom. So we are basically catching them at the end of the spectrum of the disease. End of the spectrum of disease, just like you telling me I have a stage 4 lung cancer. How you feel if I said, well, the only way I can diagnose heart disease on you when you have a heart attack. Before that, the same person had a stress test done 4 weeks ago and his stress test was normal. He walked on a treadmill for 10 minutes. Excellent exercise capacity. But he has a heart attack. Why he has a heart attack? Because the heart attack doesn't require you to have a 70% blockage. Majority of the people who have a heart attack, and we do the angiogram, we find they have developed a blood clot around the blockage, but the actual blockage was 40% or 50%. So this is a misnomer or misconception that you have to have a significant coronary artery disease to have a heart attack. No. Actually, when we see a fairly older patient who have a lot of calcification and has a 99% blockage in their heart, they're protected from heart attack. They're the one who's not going to have a heart attack. But if somebody has a 40-50% blockage, is a soft plaque, and that's kind of plaque which rupture open under the pressure and invite the clot to be made, and that's the plaque is dangerous. Well, guess what? You can do stress tests all day. You're not going to find abnormal stress tests that somebody have a 40-50% blockage. That's why you saw you see so many people have a storytelling that I have a cardiologist did a full workup on me and passed the test with flying color and have a heart attack in 1 month or in 6 months. That's a common story, and I always tell very common interesting story of Bill Clinton, that he had, when he was president for 2 terms, he had a stress test done every year. And after leaving the White House, 3 years after leaving the White House, he had a quadruple bypass surgery, and luckily recovered from it. So question is, did we miss the heart disease in our own president? Yes, of course we did. So when he was passing the stress test, is kind of false hope for it that he's doing good. He's taking Lipitor, and there was commonly you see him, he's eating burger, and when you ask him, that's not good for you, he said, well, I'm taking my Lipitor and I just passed my stress test. What else you want from me if I can take McDonald's now? So this is a common thing happening there, and we were assuming that he'll be fine. He was not fine, because he was keep building the plaque or blockage or hardening of the artery, whatever different name we call them, which is progressing, and eventually it progressed to the point where we start having a chest pain. So people who have a chest pain go to the doctor. They all usually have a heart disease with a blockage of 70% or more. That's almost like a stage 3 ovarian cancer. Nobody want to have a stage 3 or 4 ovarian cancer, because there's nothing you can do much. So our paradigm or our clinical practice trying to catch the disease at the very end, and we all agree with it, like we go with the flow. We think whatever they're saying is right, whatever they want to do is right. And even Medicare or healthcare agencies or other people will not do any screening for you, other than occasionally they do a EKG or a blood test. Well, story about the blood test. Interestingly enough, 50% of people who have their first heart attack have a normal cholesterol. Normal cholesterol. How that happened? So just the story of cholesterol and taking a statin like a religious tablet. This is happening because even American College of Cardiology or American Heart Association changed their recommendation. Now they have more liberty of using statin more often than used to be. So everybody have a mild to moderate hypercholesterolemia, needs to be on cholesterol medication. Well, that's not the end of the story. Taking medication is one thing. The lifestyle modification is the other one, which we never focus. How many times you see the American College of Cardiology or cardiologists emphasizing the lifestyle modification? They always talk about medication, pushing the medication, because there's a lot of money behind it. For lifestyle modification, there are only a few cardiologists crying for it or trying to be a champion for it, but nobody listening because they don't have money. Look at Dr. Dean Ornish. He spent all his life to study how he can change somebody's heart disease by good lifestyle, stress, modification, and diet. And luckily he found that people who does all these things reverse their heart disease, and he proved it. So he followed the patient for 20 years and found that people who were supposed to have a bypass done come to his program and did all the things he was telling them, didn't need a bypass. Their actual reduction in the plaque, this is the first time you ever see. So again, high cholesterol is not the only thing. There are other things we always look for. Lack of good cholesterol is another important thing. There are different other type of marker there. And the most important thing is genetic. Single most important thing for heart disease is the family history. If you have a family history of heart disease, premature coronary artery disease, means you have a father or mother or a very close relative have a heart disease develop before 60, the likelihood of you developing heart disease is very strong unless you change your lifestyle. So the only way you can overcome the genetic component is the lifestyle. Lifestyle is an everyday thing. It's not that I do a protein diet for 6 weeks and lose weight. No, plaque doesn't work that way. There's no fluctuation there. You need to do it for years and in a routine basis. So with the heart disease, unfortunately, we deal with the people at the end of the spectrum. They end up having a bypass, and but the good news is it's still manageable. You give them a bypass, you restore the blood flow, God gives them a one more chance, and if they do well after bypass, they do very well. Man, I have seen patient almost 25 years after bypass doing as good as anybody else can do. They have almost normal life expectancy. I mean, you have seen in CNN, our famous anchor in CNN, and he has a bypass done almost 20 years plus, and he's as healthy as can be. But before bypass, he was a chain smoker, eating red meat every day, and was a very stressful life. And after bypass, he realized that's not going to happen, so he quit smoking and not eating meat. He became vegetarian, started doing exercise and eating healthy food, and he's better than anybody else. So this is a very common, easy, manageable disease if we understand that we need to start from the very beginning. So what we should do in order to have a proactive diagnosis of heart disease. If you look at the plaque formation pathophysiology, people start making plaque in their arteries when they are young, 15 years old, 18 years old. So after Second World War, the people who died in Second World War, they did an autopsy on those soldiers. And you know, the soldiers, the actual soldier who will fight on the front of the war, usually 18 to 20 years old. They're not very old. And if they did an autopsy on those people, and they found some of them have, it looks like a 50 to 60% blockage at the age of 18. Back then, the diet was not as good as we have now. So it was very common to have a plaque build up in the age of 18 and 15. And this is the time we develop a habit. So the most important thing in personal life is the habit we develop, what they like to eat, what they taste. And it's all come from the mom. And that's why we all focusing on, in cardiology also, training the mom. What they can teach their kids to eat will stick to their life all their life. I always like something which she given to me in my first 10, 15 years of life. If I have a choice between that food versus any other food, I'll jump on that food. This is human nature. So we're focusing on teaching women about diet, because if we can teach women, we can teach everybody. Because they all gonna go from there. I'm not saying that the women are hard-headed. I'm saying that this is the way it goes. So the early diagnosis is the key. Well, we don't have any screening test available until now for heart disease. We have screening tests for almost every significant disease. So like breast cancer, we have a lot of women here. Breast cancer, we have a screening test. We do a lot of advertisement. We do walkathon. We do a marathon. We do everything to raise the awareness and all that thing. But you have to realize if you compare the woman dying from breast cancer versus heart disease, the woman will die from heart disease is 10 times more likely than dying from the breast cancer. 10 times. So the majority of the women will not die of breast cancer, will die of heart disease. And now we don't even have a screening test for them. There's no early diagnosis for them. How that happens? Because we just don't have a tools to do early identification of those diseases. And if you generalize the term, okay, if you're 40 years old and we tell them you have a risk of heart disease because you have a high blood pressure, you have a family history, blah, 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 they're not going to listen to you, or they listen to you for a few days and they forget. Because the disease is progressive, chronic, but those people, once they get MI or heart attack, that's the end of the story. That's it. And the other fact is, majority of the people who are able to go to the ER and have angioplasty done is only 50% of the acute heart event. The 50% of the people in US, which has the best facility available in the entire world, after their first heart attack even cannot reach to the ER and die before that. This is a significant mortality. Number one cause of death in US. It's almost like an emergency and crisis, if you want to call it. All healthcare expenses going into cardiovascular mortality and disease is stroke, heart disease, intervention. Majority of the money going there. If we save ourselves from dying from the heart attack, you have a congestive heart failure because you have a big muscle gone. Now you'll be congestive heart failure all your life. You may go to transplant and spend a lot of money there and have a very poor quality of life and live for 10 more years with a very heavy financial burden. So why don't we have just early diagnosis of this disease or screening the disease before it happens? Well, initially it was not available, and now it's available, but insurance doesn't want to pay for it. So the best way to make a diagnosis of heart disease is identify the amount of calcification in coronary artery. This has nothing to do with the calcium in your body. You can have a low calcium in your body or high calcium. It doesn't matter. Whenever you have a plaque buildup anywhere, plaque is, in medical term, is called atherosclerosis. Athero and sclero. Athero is a soft lipid part. Sclero is the hardening of that plaque. So initially you have a soft plaque buildup because of the lipid, cholesterol or diet we eat, and that surrounded by fibrous tissue, hardening of the artery, and the calciums come with it. So every plaque has a calcium in it, no matter what. If you even have a very minimum calcium in your body, it doesn't matter. You're going to have a plaque with calcium. There are only 1% time you will find the people have a plaque with no calcium. So you can identify the calcium in the arteries of the heart and can easily make a diagnosis if somebody already have atherosclerosis. Is it a starting process or he has extensive atherosclerosis? You can find out because the score can be 0, the score can be 5,000. So people who have a score of 400 or less do much better with the diet and exercise and have a chance to prevent themselves from the heart attack or bypass or surgery or any disaster or catastrophic changes. While if somebody have a score of 400 and more, we're in trouble. So, and it's very easy test. It takes about 5 minutes to do the test. No IV, no pain. You don't have to take your clothes off. You just lie down on a high-speed super CT scanner, which is available almost every hospital, and do the 5-minute test, and you'll find that you have a plaque or not. The dilemma is, every time you try to do a screening test, the government or CMS always look for the cost effectiveness of the screening. So, well, that will be cost effective. Initially, this test was very expensive. When this test came 10 years ago, Cooper Clinic was charging $600 just for the calcium score. And people were doing it with those people who can afford it. Now the calcium score can be done under $100. Like the Baylor Heart Hospital, they're doing $79. Here in our hospital doing in $69. And if you want to go cheaper, go to my office, we do $45. So we're the cheapest of all. But the reason we want cheapest because we want people have a screen and not to be worried about the money. This is the one thing you can do good for the community, just to have them screening done. At least they know where do they stand. And when I'm already running the machine, doing a 5-minute test, it's not going to kill me or destroy my practice. But I want to have more people have a screening done so they can be have an increased awareness. The best thing happen to them if they know they have a plaque buildup and they visualize it. That's the biggest thing. Until then, you can tell a story all day. You can give them a teaching and education and all this. Just like, again, I give you the example of church. We talk about God. Well, we believe strongly that God exists. But we still have imagination. We haven't seen God yet. Probably that will be the last thing we have if we actually God showed up. Because, it will be overwhelming for us. But people, that's why the people don't follow the religion as much. They forget about there's no visualization. Although there's a lot of people believe and do the right thing based on their beliefs. So seeing is believing. In this case, if you show them their plaque, their compliance with medication, they're listening to the physician, and they are reading about it. They get conscious about it because they know what is inside. If you show them the mirror, before they were not listening to you, now they are listening to you. So that's the other thing happened with the calcium score is people know and be careful about their heart, and they have increased awareness, and they change their lifestyle, and they start looking and taking care of themselves. So there has to be something to see and believe and do the right thing. So right now the Medicare is supposed to pay for screening test. Sometimes they do, sometimes they don't. Most of the insurance company don't. So we do it so cheap that it can be done. But not everybody needs to have a calcium score done. Majority of the time, at least they need to have 1 or 2 risk factors. Somebody is 40 years old, strong family history of heart disease, high cholesterol, I will definitely do it. If somebody, a young woman come 35 years old, mitral valve prolapse, no history of heart disease, doesn't smoke, atypical chest pain, there's no need to do calcium score. So we're not saying that you have to do calcium score on everybody, but identify the people and do it. And we found that if you look at the Framingham risk factors, the traditional based on famous Framingham study, if you look at all the risk factors, hypertension, male gender, smoking, diabetes, high cholesterol, whatever genetic factors are, you combine them versus calcium score. Calcium score is much more potent and more predictable of heart attack in the future or cardiovascular disease in the future than all of them risk factor. It's the best predictor of heart attack than anything else we practice in medicine, no matter what equipment we have. It's the simplest test will tell you if your likelihood of having a heart attack in the future. Simple test. But once you have a bypass done, there's no need to do a calcium score because you already have a diagnosis. The calcium score is done to do a screening to find out if you have heart disease or not. Or sometimes we do for progression of heart disease. And that's we can do also in bypass patient. So if you look at back and if you look at your family, you have son, you have a daughter who reaching to the age of 40, 50s, and they have a strong family history, just like because you have a heart disease, you already created a risk factor for them. So encourage them to get their scan done. Encourage them to read about it. It's nowadays it's very easy to read about those things. Just Google it. You'll find tons of articles about basic reasoning, rational for the heart disease. So now what we practice, it may not be the recommendation. It's still the recommendation body, not calling is a clinical one indication to do screening on everybody, but they know patients who have a risk factor, they will do it. Even those people who are writing all the recommendation for everybody, they in their private practice do the calcium score on everybody who they think have a high risk for heart disease personally, and they do on their own themselves. All the cardiologists who practice cardiology have a calcium score done.